Okay, let's study palliative. So, pain is important and we need to manage it to avoid a lot of problems. Okay, let's learn the WHO analgesic ladder. So, the analgesic ladder is 3 steps. The first step is a patient experiences pain. We give them a non opioid, whether a paracetamol or non steroidal, plus or minus adjuvant therapy based on the type of the pain. Um, Step 2, the pain persists or increases. So we give a weak opioid like codeine or tramadol. And in the UK, we can also use low dose strong opioid in this case. Um, Plus or minus, like we can add it on the non opioid that we have already been given and the adjuvant. So the pain is severe from the beginning, or it persists or increases. Even after step 2, we give a strong opioid like morphine. So, the principles of opioid prescribing is that we prescribe the minimum dose needed to achieve analgesia. Morphine is the drug of choice, and the starting dose is 5 to 10 milligrams every 4 hours. And then we add required doses up to every 1 to 2 hours. The added doses that we add as required, we add them to the next day's regular dose. And we keep on doing that until we have a stable daily requirement that relieves the pain, okay? So that's how we do the up titration, and it's kind of like a phase until we decide on the stable daily requirement for this patient. And then we give it as a modified release preparation, and then we give 1/6 of it as required for breakthrough pain. When we increase the opioid dose, we increase it by 30 to 50%. Oral is preferred to transdermal patches like fentanyl and buprenorphine, which is administered every 72 hours or weekly. Modified release covers for 12 hours. So, for cancer pain and chronic non cancer pain. For cancer pain, there is no ceiling effect to morphine. However, for non cancer pain, there is a limit to the usefulness of morphine. One of the most important adverse effects of opioids is constipation. So, all patients on opioids should be given a stimulant laxative like senna, plus a stool softener like sodium docusate. So, senna is a stimulant laxative, which means that it stimulates epithelial cells to secrete electrolytes into the lumen of the colon. Okay, and we give a docusate with it. Okay, the emollient. There are other types like osmotic laxatives, like lactulose, macrogrol, and rectal phosphates, and these could be added to senna. Okay, and then there's the other types of laxatives, but the main 2 types are osmotic and stimulant laxatives. Okay. For nausea, we can add antiemetics. For drowsiness, we adjust the dose. For itching is also an important side effect, and it is less in fentanyl. Or is it more in fentanyl? Why did I just write fentanyl and not explain? It causes less itching, so it's better in terms of itching. Like if a patient has itching, we can switch them to fentanyl. For oxycodone, it causes less sedation, vomiting, and itching than morphine, but it causes more constipation. The lowest risk of constipation is with meptazanol, sorry. The analgesic effect of codeine depends on its conversion to morphine by the CYP2D6 hepatic enzymes, and 10% of Caucasians are poor metabolizers of this drug, so basically they will not benefit from codeine. Okay. Now, to convert between opioids, for the weak opioids like codeine and tramadol, they are 10 times weaker than morphine. Okay, so we have to divide by 10 when we're converting to morphine. Okay, now for oral morphine to oral diamorphine, we have to divide by 2, meaning that diamorphine is double the strength of normal morphine. Same thing goes for oxycodone. Oxycodone is 1.5 or 2 times stronger. Now, when we're converting to subcutaneous is also 2 times stronger. So you have to basically divide by 2 as well. For subcutaneous diamorphine, you have to divide by 3, right? Because subcutaneous is stronger, and then diamorphine is also stronger than morphine. For oxycodone to diamorphine, it's 1.5. Okay. And then for the transdermal ones, you divide by 2.5, okay? From weak to strong, the weakest is codeine and tramadol, and then morphine, and then oxycodone is the strongest, I guess, and the transdermal ones are also strong. Now, when we're choosing the pain management option, we have, if there are no comorbidities, we give an oral modified release morphine 20 to 30 milligrams per day. And for breakthrough pain, we give 1/6 of that as required. If we have renal impairment, we cannot give morphine. Morphine is metabolized by the kidney and it accumulates in renal failure. So we give other options, which are basically oxycodone or fentanyl or buprenorphine, like the other three, right? So oxycodone is a better choice in renal impairment than morphine. For hepatic impairment, though, you have to avoid oxycodone because oxycodone is metabolized by the liver. Next step up for pain that is not controlled on paracetamol and non-steroidal is a weak opioid. This is just following the ladder, right? Okay. So codeine and tramadol are the weak opioids. Now, for pain and constipation, you give mepetasonol because it has a lower risk of constipation than the other drugs, like we said. For bone pain, we add naproxen to opioids. For metastatic bone pain, we give strong opioids, and then we also give bisphosphonate, denosumab, or radio. Okay. So for metastatic bone pain, you give morphine, you give strong opioids regardless, and then you can give, bisphosphonate, denosumab, or radio. For oral pain, we give a benzidamine, hydrochloride mouthwash, which is basically a topical non-steroidal drug. And then for headache, we give Dexa because it's caused by increased intracranial pressure. Avoid opiate analgesia in medication overuse. Opiate analgesia is associated with medical overuse headache. Okay. For liver capsule pain, we also give Dexa. For pancreatic cancer or chronic pancreatitis related pain, we do a celiac plexus block. For neuropathic pain, the adjuvant is going to be gabapentin, pregabalin, or amitriptyline. Amitriptyline can be taken at night because it's a mild sedative, so it also helps with the quality of sleep. So if you have a patient with neuropathic pain who also has trouble sleeping, amitriptyline is a good choice. Nerve blocks are given when opioids are insufficient and can reduce the need for escalating systemic opioids, which could worsen side effects, like how we did it in the pancreatic cancer pain. So these are just some notes on abbreviations. Cocodamol is codeine plus paracetamol. PRN is as and when required. BD twice daily. TDS 3 times daily. QDS 4 times daily. Okay. Now, for the other symptoms like nausea and vomiting, if it's chemotherapy related, we give ondansetron, which is a serotonin blocker, or aprepitant, which acts on the NK1 receptor and inhibits substance P. I don't really know what that is. It's a selective neurokinin receptor. It inhibits substance P. What is substance P? Anyways. If we have a chemical cause of the nausea and vomiting, like hypercalcemia, we give haloperidol. Haloperidol is a dopamine blocker, and hypercalcemia usually causes nausea and vomiting by stimulating the dopamine receptor, so we give haloperidol. For mechanical causes, we give antiemetic, and then we can give levomepromazine or corticosteroids if it's due to edema. If we have gastric obstruction, if we have gastric stasis and distension, we give a prokinetic like metoclopramide, and then if we have increased intracranial pressure, we give cyclizine. And then I also have the Oxford palliative section. I also want to read the management of nausea and vomiting here. So we treat reversible causes. So constipation, we give laxative, and pain, we give analgesia, hypercalcemia, fluconazole, blah, 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 blah. It is based on the mechanism of nausea. That's how we choose the drug. So cyclizine, it's good for intracranial disorders. Is that what we said? Yeah, exactly. Metoclopramide is for gastroparesis. Domperidone is for it's a peripheral antidopaminergic, so there's no dystonic effect. We chose an antidopaminergic in chemical causes. Haloperidol as well. It is effective in drug or metabolically induced nausea, like hypercalcemia. Ondansetron is good for chemo or radiotherapy related nausea, but it may cause constipation. And then levomepromazine is good for. I feel like we chose that for the gastric blockage, right? Yeah, gastric obstruction. Okay, and then anti-secretory drugs are also for patients who have vomiting and bowel obstruction. Now, for constipation, it's a common side effect of opioids, so we usually prevent it by prescribing laxatives for all patients starting opioids. We give Senna plus or minus a softener. This is what we do. And then another thing that could be added is an osmotic laxative as well. Okay. Now for bowel obstruction, we're going to give metoclopramide, and if it's partial, if it's complete, don't give metoclopramide. A prokinetic, give an antispasmodic like hyoscine, and haloperidol as an antiemetic, and then there are other options as well. For breathlessness, the issue is that the breathing problem can be like breathlessness can be caused by three issues, whether it's a breathing problem like dysfunctional inefficient breathing, or a functioning problem, deconditioning and lack of exercise, or a thinking problem, patients' own thoughts and feelings could cause them anxiety and then lead to breathlessness. So severe breathlessness that's not responding to non-pharmacologic intervention, you prescribe morphine or mirtazapine. Do not give benzo, do not give oxygen. Only give benzo at the end of life. So if a dying patient has breathlessness, you give morphine and midazolam subcutaneous pump. So yeah. So for secretions, we're going to give conservative management, avoiding fluid overload, and then educating the family that the patient is not troubled by the secretions. It's usually the family who are more troubled by it. And then we could prescribe hyoscine or glycopyrronium as a second line. Hyoscine is better, it's less sedative. For dry mouth, we just keep it moist. For agitation, we treat these underlying causes, and then we give haloperidol, antipsychotic, or other second line like chlorpromazine or levomipramazine. If it's a terminal case of illness, breathlessness, pain, anxiety at the end of life, we give subcutaneous midazolam. An end stage patient who's still breathless, you just give them a low dose benzo. Okay. Now for intractable hiccups, you give chlorpromazine or haloperidol. We use that drug a lot. We used chlorpromazine for hiccups, for agitation, for yeah, that's it. Yeah. And then we use haloperidol also for hiccups, for agitation, for also for nausea and vomiting. Okay. And then also gabapentin, and then if it's hepatic, then dexa. Risk feeding is basically a decision to allow someone to continue eating despite the risk of swallowing, and it's basically a choice that is made when individuals prioritize the enjoyment and quality of life other than the potential health risks. For hospice and nursing, there are some terms that I need to know. So Marie Curie nurses, they offer nursing care for patients who wish to die at home. Macmillan nurses are cancer nurses. Admiral nurses are dementia. So Admiral, dementia, Macmillan, cancer. And then Marie Curie just wants to die at home. For the gold standard framework is a framework for patients with life-limiting conditions that allow them to make health plans in advance before they deteriorate. Independent mental capacity advocate can make a decision when patient does not have capacity. So hydration, clinically assisted hydration in the end-of-life care may cause problems such as fluid overload. Okay, now syringe drivers. Syringe drivers are considered when patients are unable to take oral medications due to nausea, dysphagia, intestinal obstruction, weakness, or coma. There are two types in the UK. Grasby, the blue and the green one. Okay, the blue one is a rate in millimeters per hour. The green one is rate in millimeters per 24 hours. Most drugs are use water as a solution. Some drugs, like OK, they use sodium chloride, so octreotide, ketamine, ondansetron, granisetron, and ketorolac. Okay. So the commonly used drugs, again, for nausea and vomiting, it's cyclizine. If it's intracranial pressure, levomipramazine. If it's GI obstruction, haloperidol if it's mechanical, metoclopramide if it's GI stasis or paresis. Let me check. Yeah, that's basically it. Okay. Now for cyclizine, it's incompatible with clonidine, dexa, hyoscine. It's incompatible with a lot of drug, and it also may precipitate with diamorphine, and it's highly acidic, so it causes drug irritation when given subcutaneous. So you also need to make sure that you're aware of what's compatible when you're mixing. And then, yeah, diamorphine is compatible with most other drugs. So medications run through syringe drivers over 24 hours, and they're prescribed as such. So patients should have a new syringe set up every 24 hours, and after setting a syringe driver, the palliative care guidelines recommend that it should be reviewed every 4 hours to check for precipitation clouding. So we check it every 4 hours, and we change it every 24 hours. And then we don't change the subcutaneous needle except every few days, unless the patient experiences erythema at the injection site. Now, do not attempt resuscitation. The overall responsibility for resuscitation lies with the senior doctor, the consultant looking after the patient. And in some hospitals, junior doctors can complete DNR paperwork, but they must be signed by the senior doctor. Okay. There must always be an assumption in favor of performing CPR, regardless of how frail the patient is. DNR decisions should be discussed with palliative patients prior to any deterioration when they're able to consider it communicate. And the GP or specialist managing the patient's condition may be able to lead that discussion. And we have to make sure that the patient has capacity to, basically give a DNAR decision. Now, I just need to check that the palliative book doesn't have anything else. Okay, there are 5 principles for effective analgesia. By the mouth, so give orally whenever possible. By the clock, so we have to give it at fixed intervals. By the ladder, we have to follow the WHO stepwise approach. For the individual, there are no standard doses. That's why we use starting dose, and we up titrate depending on the patient. And then attention to detail, so we communicate, we set times carefully, and we warn patients about side effects. And we've already read the ladder. For opioids, start low, go slow. So we already learned how to start. Again, we said for renal, you stop morphine, you give oxycodone, right? Yeah, I'm pretty sure. Unless it's a liver patient. For pain, you give morphine. For agitation and nausea and vomiting, you give haloperidol. For agitation and anxiety, you give midazolam. For nausea and vomiting alone, you give levomiprazole. Okay. To manage agitation, you give benzo if it's a dying patient. Patients who are thought to be at the end of life may improve. Be alert. Communicate. Okay, thank you. Bye.